Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your co-host, Brian Waterman, the sports and shoulder elbow surgeon at Wake Forest. I'm fortunate to have Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, as my co-host. Peter, how are you doing today?
Oh, I'm doing great. I'm really excited to do this.
Certainly, we're fortunate to have another guest co-host, a special guest, and that's Robert Hartzler, coming from TSAOG in San Antonio, Texas. Rob, welcome to the podcast.
Gentlemen, thank you very much. It's a pleasure to be on.
All right, before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons, the University of Utah, Wake Forest University, or any of the institutions of our guest. Without further ado, it's our distinct honor and privilege to welcome one of the seminal figures in the field of shoulder arthroscopy to the podcast today. With over 4 decades in the field, Dr. Steve Burkhart's endless list of accomplishments are impressive to say the least. He has 80 U.S. patents, 220 peer-reviewed publications, countless podium presentations, several chapters and textbooks, including 3 from the Cowboy Way series. It's truly our honor to welcome Dr. Steve Burkhart to the podcast. Steve, welcome.
Well, thank you very much, Brian and Peter and Rob. It's a pleasure to be here. Appreciate the opportunity.
Well, let's dive in. Dr. Burkhart, it has just been so amazing to drink from the fountain, and I'd love to be able to start at the beginning. As I understand it from Rob, who was my source of intel for much of this, you're among the busiest general orthopedic surgeons in South Texas and performing as many total hip to knee surgeries as anyone around. Tell us what initially drew you to the field of shoulder surgery.
Well, I started practice in San Antonio in 1981, and I was in the same practice until I retired in 2020. So, my longevity was all in the same location, same group, but it changed a lot over that time. When I started in practice in 1981, my senior partner, Dr. John Hinchy, was a local legend. He was the first orthopedic surgeon in South Texas. He had gotten a start by coming to San Antonio, and he would basically ride the circuit to the small hospitals around, and he would operate in these small community hospitals in the small towns. And our group still did some of that even after I started. And so we would, for example, when we were on call on a weekend, you might get 2 or 3 calls from outlying communities that had people with hip fractures, and you'd have to arrange your schedule to go out there to these small towns and do the itinerant surgery. And we had a traveling set of instruments, and we would take. You never knew exactly what the fracture was going to be, and we only did hip fractures at that time. But we had hemiarthroplasty. We had osteomorphosthesis in case it was a displaced femoral neck. We had Knowles pins in case there was an impacted femoral neck fracture. We had a Jewett nail in case it was an intertroche, even if it was an unstable intertroche. So we had to do a lot of that. We had to do it on sometimes in rooms that were converted, really not much different from somebody's dining room with a dining table in it. And that's what one of my partners told me. He said, "We're going to teach you how to do a hip fracture on the kitchen table." So I was expected to do everything. I was doing general orthopedics, but I was joining a 6-man group at the time, and they wanted everyone in the group to have an area of special interest and expertise, even though he was a general orthopedic surgeon. So I was hired to do general orthopedics, but my areas of expertise were supposed to be, number one, sports medicine, and I did a sports medicine fellowship with Bob Larson up in Eugene. And number 2 was shoulder, just general shoulder surgery, because I had done the shoulder rotation at Mayo Clinic during my residency. And at that time, Mayo Clinic had one of the few FDA ID numbers that allowed them to do the glenoid components for total shoulder arthroplasty. So you couldn't really learn to do a total shoulder glenoid and humeral side very many places. So they thought that would be ideal. So I was the sports guy and I was the shoulder guy. And but I was expected to do all these other things. And Dr. Hinchy had been the first orthopedic surgeon in South Texas, or I think probably in the whole state, to get an ID number from the FDA to do total hip replacements back about 1970. And so he had gotten this reputation as a total hip, total knee guy, and there was so much overflow from that, they expected all of us to do a lot of total hips and total knees. So that's how that happened. So I did a lot of total hips, a lot of total knees, and then I got all the difficult shoulders for sure, which they were pretty much all considered difficult back in the day. No one wanted to take care of them, and I can get into that later. But and then since I'd done the sports fellowship, which in those days was mostly knee surgery, I did ACLs and was team doctor for some high schools and for one university also.
So you mentioned that back then, that all the shoulders were considered difficult. And I think you've made a bunch of like real specific contributions that have decreased the difficulty. One of the things that I think is really remarkable is you've really contributed to our understanding of the anatomy and biomechanics of the rotator cuff with this kind of cable and crescent concept. And it's interesting looking back through papers. I mean, there's this early paper with fluoroscopy, and then there's this second paper kind of really describing the suspension bridge concept. Where did you come up with this idea? Like, where did you come up with this suspension bridge concept, and how did this alter your understanding of the cuff as you approached a joint that at the time maybe was something of a mystery?
Well, that whole idea of the suspension bridge came to me as a result of doing open rotator cuff repairs early in my practice. And I always thought that crescent shape to the tear, generally if it was a supraspinatus or suprainfraspinatus tear, I always thought it looked like the Golden Gate Bridge. And I thought probably the biomechanics are going to be similar. And then, but that was just looking at a tear. That's not looking at the intact specimen. And then later, as I started doing diagnostic arthroscopies and looking into the joint, you would see the rotator cable crescent, which no one had ever described up to that point. And I thought, well, probably that cable is going to be stress protective of the crescent, which is distal to the cable. If it's going to behave similar to a catenary equation, like for a suspension bridge. And so I decided that actually then resulted into one of my earliest biomechanical studies, where we did some biomechanical studies on the cable and crescent, and we did find that the crescent was stress protected by an intact cable. And then, of course, we did another study. There was an anatomic study to just define more or less what that structure was, where it was located, where the anterior cable attachment was, where the posterior attachment was. And so those two papers were the beginning of trying to relate the torn cuff to the intact cuff. And it was kind of ironic because at the very beginning, this was sometime back in the 80s when I first started thinking about this. And it was, there was no good way to repair the rotator cuff at that point arthroscopically. There weren't any ways to do a transosseous repair arthroscopically. Suture anchors had not come on the market yet. And so I was looking at it primarily thinking about whether it would make sense to debride some of these smaller cuff tears if the anterior and posterior cables were intact. And I actually did a number of those back in the 80s, early 90s, where they had normal function and their main problem was pain. I just did decompression and debridement around the margins, but trying to preserve the thicker cable attachment. And so ironically, as much as Dr. Rockwood and I were in conflict over the years, he was encouraging me in San Antonio to pursue that research, because at that time he was publishing about open debridement of rotator cuff tears, and he was probably debriding more tears than he repaired at that point in his career. And ironically, he was one of my sponsors to get into the ASES because of that work. Of course, after he found out later that I was doing things arthroscopically, he was less than enthusiastic about some of my work, but he was one of my two sponsors for getting into ASES. So that's kind of ironic.
So it's hard to even imagine. I mean, I've read the earlier paper you have on kind of the results of debridement for the cuff, and there's obviously a lot of other good outcomes published. You know, Boileau's paper is probably Boileau and Walsh's papers are the most frequently talked about, but the results I think are all the same, and it sounds like you and Rockwood, same results there. Then the suture anchor comes on the market. So tell us just real briefly in that moment, like when did that happen? When did you start using that? Were the early suture anchors easy to use, hard to use? Tell us about that transition toward debridement to repair.
The first anchor that I recall being available commercially was the Mytech G2 anchor, which was approved as a labral anchor, I think. I don't believe it was ever approved for rotator cuff, although then Mytech later came out with the G4, which had the four prongs to it that I think was approved for rotator cuff. But even into the early 90s, I was convinced that transosseous was the way to go, because I went into this with a bias, thinking that if you just replicate arthroscopically what's done open, then that we know that the transosseous works, and so let's just not reinvent the wheel. Let's just find a way to do that arthroscopically. And when I first was approaching various companies and finally got someone interested in it, which was Arthrex, to pursue some medical device designs with me, the first thing I wanted to do was a transosseous jig system to do transosseous cuff repairs, and we had a system to do that. The problem, in order to be sure that you had good purchase in bone, you had to go pretty far distal, and you had to go so far distal that after doing some anatomic studies, I decided we needed to have a subaxillary nerve portal to start that transosseous tunnel. And so, obviously, once your shoulder gets quite swollen, it's hard to know where exactly subaxillary nerve is on the deltoid. And so I tended to err, if anything, too far distal, thinking that, and never putting the nerve at risk on that. But still, I thought I did about 20, I think I did 27 of those, and they turned out pretty well overall. And they were all arthroscopic, transosseous. This would have been sometime in the early 90s. And I thought it was too dangerous to recommend to the general orthopedic public. I thought, I don't want to be the reason somebody gets into the axillary nerve. So Arthrex, to their credit, after having worked with me on that, they didn't market it based on what I had told them. But about that time, it was obvious that the Mytech anchor was taken off, and you could put the Mytech anchor in, or any anchor in, without any danger to the axillary nerve. And I thought, well, that makes sense. We just need, but I didn't like that particular anchor. I didn't like and particularly for rotator cuff, we needed something with much better pullouts and that type of thing. But then I had to change my mindset about this whole idea of how to fix it. I had gone into into it thinking, okay, we're going to do transosseous. We know that works. It's got decades of confirmatory experience to show that it works. But we don't know about suture anchors, particularly with the rotator cuff. So at that point, I had a mechanical engineering degree as an undergrad. I went to Rice University and thought I had actually wasted that time to get that degree. As it turns out, it came in really handy because I thought, I don't know of anyone else that's interested in shoulder arthroscopy right now who has any biomechanical background. So I took it upon myself to design some cyclic loading experiments, and I had access to the lab at the Health Science Center in San Antonio at that point at the University of Texas, and had become good friends with the head of that lab. And I talked to him about doing some cyclic loading studies of comparing transosseous. Well, first off, even before that, we started seeing how secure we could tie knots arthroscopically. And, I had come up with this 6-finger knot pusher, and then there were the other knot pushers. And it was a matter of not only knot security, but loop security. So I did all the studies. In fact, we defined loop security. There wasn't even that concept out there. But, obviously, if you tied a tight knot, but it had a loose loop, it was going to fail. So we did that first, did all the knot studies, how to tie the optimal knot, and then we did the two papers on cyclic loading of repairs. One was the traditional transosseous repair, which would be done open. The other one was an arthroscopic type of repair that's done with suture anchors. And then we did the cyclic loading, and what we found was really surprised me, because not only was the suture anchor repair stronger than the transosseous. That is, its ultimate load was higher than the ultimate load of the transosseous, but it shifted the weak link of that entire construct from the bone suture interface over to the tendon suture interface. So basically, you had optimized your bone fixation. I mean, we immediately saw that the bone fixation was optimized through suture anchors as compared to transosseous. The transosseous on cyclic loading would cut through the bone like a cheese cutter. And particularly since, the way the typical transosseous was done, that lateral hole was never down very far distal. It was never down into cortical bone. It was always just up there in that thin shell above the cancellous bone. So anyway, I learned a lot from that. But the important thing about those two studies was, to me anyway, it immediately gave us an ethical basis to conscientiously explore this suture anchor technique. Because if you're thinking about suggesting that you're going to totally change the paradigm of how something is repaired, particularly in surgery, it's irresponsible to suggest that you're going to do something without knowing if it's as good as the existing method. You have to show that it's as good as or better than. So immediately we knew that biomechanically it's stronger than what we've been doing. So it's just a matter then, okay, we know it's stronger, then we don't have any instruments to do it. Let's figure out the instruments and the implants and the sutures and all the steps we had to go through to get it even stronger and to get it down to a point where you had instruments and implants that were easy enough to use where an average orthopedic surgeon could do them. And that's one other thing. There were some of the early guys like Steve Snyder and Jim Ash, those guys, I've said this before, but they were so talented. They could do these arthroscopic techniques with very crude instruments. And I used to say that I think they could use a knife and fork and do an arthroscopic repair, either cuff or instability. But that's not good enough. You can't just have 3 or 4 guys in the world that can do this and nobody else can. And so our goal, to get this, after feeling that it was going to be the way to go, then we had to take on a bunch of other, burdens in terms of, it wasn't just development of instruments, it was educating a critical mass of surgeons to take care of the critical mass of people that was going to be wanting this done once it got out there. So it became apparent probably in the 90s that it was going to take decades for anything to happen. So we had our own little support group, those of us in the early days who were doing this, and we were kind of pariahs from the mainstream, from the establishment, but that was okay. We were all young and naive, but we were outside the establishment, and I think that protected us a little bit. We were in private practice, but we didn't have any academic or orthopedic political aspirations at that time. So nobody is going to threaten us by ruining our academic career because we didn't have one. And as long as our patients got good results and we were happy with it and our partners were happy with it, then, we could console each other. And we used to also say, well, at the very worst, we know how to do these things. So even if we can't teach anyone else how to do them, we've got job security for the rest of our careers.
Such an important part of our narrative history of shoulder surgery. I mean, these studies are truly foundational. It's kind of staggering to think how little we've progressed since your early career. I think your background in biomechanics is certainly on full display, but I think more importantly, it's your knack for conveying these fairly complex principles in a very pragmatic way. And so that's the lead in to say that, your Western references are often speaking from your roots in Texas. And I would say that they're pretty firmly entrenched in our orthopedic lexicon. These have been driven by your Cowboys Guide, certainly the Cowboy Way course that you chaired for several years. But you really truly have a gift for identifying these gaps in knowledge and challenges we face in surgery and generating these novel solutions. I think about the concept of the dead man's ankle, the buddy anchor, the diamondback repair, the snubbing post. I'm curious to dig in a little bit more on your process for innovation and troubleshooting.
Well, one thing always kind of leads to another, it seems like. I've always thought that I didn't start out to be an inventor of instruments or anything. It's just that there was nothing else out there, and I had some ideas. And but as I got more and more into it, and I saw what worked and what didn't work, I always thought that the best invention was one that you would show to just an average person in your field, and they'd say, "Gee, that's really simple. I wish I'd thought of that," or "Why didn't I think of that?" And I can't tell you how many times I've seen things where I thought, "Gosh, that's so simple. It should be obvious, and I didn't think of it. Why not?" So, and there are a lot of simple things around us, and a lot of the ideas have come from simple things that I've seen, but not really applied the lessons of it. And then you layer onto that, I guess, some knowledge of mechanics, of mechanical engineering, and maybe just enough to maybe. And I don't know that it's good or bad, but I mean, I haven't invented anything that was that required like really deep expertise in nuclear physics or anything like that. They're all pretty simple things, and there are examples around your garage or your house or your kitchen or something probably you can find. And so sometimes something will hit that I see, and I think, okay, so what's an analogous type of thing in my experience? And I guess this is a roundabout way of explaining, I guess, about some of the early Nautilus fixation. I actually did a paper on this back, I think it was published around 2003 or something like that. But it explained in that paper, I had made a trip. My first trip to China was in 1998, and I was a speaker at the Hong Kong Orthopedic Association. And my host there was an orthopedist named James Lamb. The second day I was there, we went to a restaurant, and they were renovating a building that was about a 25-story building across the street from where we were having lunch. So James told me, said, well, after we're done, I want you to come and look at this. He said, the scaffolding that they're using is all bamboo scaffolding, and it's held together with leather lashings. And they wrap these around there and turn them back on themselves, and there's not a knot in there anywhere. And he said, the most recent skyscraper that they've finished here is the Bank of China, which is 100 stories high, and they use bamboo scaffolding all the way to the top of the 100th story. And people trust their lives to this knotless type of fixation on a bamboo scaffolding. And I couldn't get that out of my mind for the next several weeks. And so I started thinking about why that was, and broke out my old engineering books after I got home, and I said, well, it's got to be cable friction, which is something we had learned about, it's friction of one surface against another when you have a kind of even a slightly complex relationship between the two. For example, the snubbing post with a horse. I had never known why a snubbing post, where you can wrap your rope, the lead rope for your horse, around that post, and all of a sudden it's much easier to hold that horse. You could never hold him if you just had the rope itself, but you wrap it one revolution around that post and you can hold him all day. I never quite understood why that worked, because I never thought about it. But that's cable friction. And the same thing, if you wrap those two leather lashings around each other, they develop a type of cable friction. And so I started thinking about how we could utilize that concept, and I came up with an anchor that we use. It got FDA approved. It's called a twist lock, where you would actually, before you dunk the anchor down in the bone for a rotator cuff, you would twist it 3 times where the suture would wrap around each other. The problem was in the insertion of it. And this would have been, when we finally had these made, was around 2000. And we just had Ethibond suture then. We didn't have any high-strength suture. So when you'd start to dunk it in, you would abrade this Ethibond suture around the corner of the bone where the anchor was going in the bone socket. And about half the time it would break the suture. And that later became an impetus for developing the fiber wire, which the main impetus behind the fiber wire was Don Grafton, who was the Arthrex chief engineer at the time. But at any rate, I was thinking, well, we're just going to have to keep using this weaker suture. How can we minimize the abrasion? And I thought, well, we'll use an extended tip inserter, where the inserter goes through a cannulation in the anchor, and it has an extended tip that's equal in length to your anchor, and it would be a screw-in anchor to optimize the fixation in the bone. And so that would then, you would just put your suture through the eyelet at the end of that, and then you would dunk that down into the bone, and there would be no abrasion to speak of, because you could have it all be very loose and lax at the time. And then you would pull the slack out of it, and then you just screw in the anchor over the top of that. Or you could have a pound-in anchor, a push-in anchor, but there was the extended tip. So at that point, where you were going down and around, and you had an eyelet at the end, you had cable friction against that eyelet. So you dramatically, it was like the snubbing post of the horse. So, but that wasn't the first iteration of swivel lock. The first iteration actually was another cowboy idea, where if you have if you want to have an adjustable loop and you want to change how tight your loop is, if you're going to do that out on the ranch with a fence post, you use a chain and you choose the appropriate link in that chain for the hasp of your lock to go through or whatever, of your fastener. So before we did, the fiber wire and then later the fiber tape, we had a thing. It was my idea to have it was called fiber chain, and so you would have we made fiber wire into a chain, and so you would choose the appropriate link on that chain, and then if you chose the wrong link, you could put it down. You could put it down tentatively down in the hole, and if it was the wrong tension, you could take it out and get a different link. But there was a certain fiddle factor there that made it hard for some guys to do, and it was a small link. So once we had come up with the fiber tape, which was my idea on that, to use tapes, because I had done some study on fixation with tapes versus sutures, and once we had the fiber tape, then it became obvious we didn't need the chain anymore, because the tape was so easy to just put it one time. Outside of the body, you put the tape through the eyelet and then you dunk it down in the hole. Because with a chain, you had to actually arthroscopically find that link, the proper link, and put it in. So all these things developed over time. You'd find what's the rate limiting step in terms of what takes you the most time, what has the worst fiddle factor, and how can you improve that? And do you improve it through means of your technique or through means of your materials, or a combination of the two? And so it's just kind of trial and error. And a lot of it kind of was just, it was reinforced by, the progression of our development was sort of directed by what we found in these various cadaver labs. What could guys do and what could they not do? What was easy, what was hard? It was hard for guys to tie knots. It was hard to teach guys to tie knots. And so that was an impetus toward coming over to some sort of a knotless method using things like tape plus anchor type of fixation. So
one of the things that I think is so remarkable about your story, and it's so useful to hear, is that this was an iterative process, that it's not like you were gifted the brilliant idea of the swivel lock and it was perfect from the beginning, that there were multiple failed attempts, that you started first with, I'm going to do it transosseous, and then I'm going to do the twist lock, and then I'm going to do the swivel lock, but it doesn't work because the suture's tearing, and so I need to do a different suture, and then I tried to do a chain, and that didn't work. And what I think is so beautiful about the story for many of our listeners who are young and early in their career is to understand that, like, to succeed first, you must fail. And one of the questions I want to ask you about that is, you've throughout your career, you've done so many things where you've done really challenging things. You fought the ASES and Dr. Rockwood when it came to arthroscopy. We've heard from Rob that you had to do a lot of things, building your group into such a large group and building out your surgery centers, et cetera, et cetera. Where did this come from? Where did your ability to overcome, these challenges come from? Like, what is the reservoir you tap into that enables you to keep going?
Yeah, I don't know if I can explain that very easily or not. I think we all have to look at where we came from and who our role models were and who our families were. I think my parents were not educated people, but they were really resilient, and they were both very smart. I grew up in a small town, and it was right after World War II. I was born in 1949, so there was a lot of optimism with that generation. They'd been through Depression. They'd been through the World War. They had to be problem solvers. And in this small town that I grew up in, most of the men were pretty independent. They knew how to repair their own car. They knew how to, they wouldn't pay somebody to build a fence at their house in their yard. They'd do it themselves. And so I think there was always this idea in looking at my dad and his friends, and that they weren't going to be intimidated by a job or by a situation. And so they were all pretty tenacious, I think. And if things didn't work right at first, that's so they didn't give up. They'd go back and do things, have a bit of a revision to their plan. And then I guess I'd always admired that. And I admired it in the few professional people there were in our town. My family doctor was actually, it's back in the day when your general practitioner was not just a pill pusher, but he'd take out your appendix and he'd set your leg when you broke it and put a cast on it. And so those people could do a lot of different things, and I just admired what they could do. I think that maybe that was part of it. I don't know. The other thing, and I think that probably gave me a bit of, I guess you might call it, some people would call it an attitude probably, but it made me not afraid of confrontation. And so I think that's really what you're getting around to. Why was I okay with confronting Charlie Rockwood? Why was I okay confronting our competition in San Antonio and for our practice surgery center and that sort of thing? And confrontation never really bothered me too much. And I think that's, whether that's good or bad, I don't know. I think that leaves you open to a certain number of, kind of liabilities if you have too much of that. But I guess I wasn't afraid to do something hard. And the other thing too, it kind of fits in with that cowboy spirit. I mean, one of my favorite quotes, my dad would say this all the time: "No man ever drowned in his own sweat." So you shouldn't be afraid of hard work. And that was the other thing. I was never afraid of hard work. The other thing where I was very lucky was, I think that I found early on in my career that my hobby and my job could be the same thing. I really loved my job, and particularly when I got to concentrating on shoulder arthroscopy, and even when it was mainly knee arthroscopy. And so I didn't mind putting in extra hours after work on just thinking about some of these things and getting involved in some extra things, whether it was teaching people how to do surgery or whether it was instrument and implant development or whatever. And also that was kind of facilitated, I guess, by the fact that I'm not a golfer. I don't, that just freed up some extra time because I didn't golf. So anyway, I don't know if that's the answer you wanted, but that's what just popped into my mind.
Steve, that's so meaningful to us. I think I love everything you said, and obviously you've navigated this controversy, and nowhere was this more animated than when talking about the conversion to minimally invasive and arthroscopic shoulder surgery. You talked about how you were framed as an outcast for what at the time was seen as crazy ideas. I think history would judge you differently. You alluded to this arthroscope as being a tool of the devil. To paraphrase Jack Houston, why stare through the keyhole when you can just open the door and walk right in? I really want to dig in a little bit more on the early counterculture days of shoulder arthroscopy, particularly one that was dominated by open surgery. Can you just share what that was like, the process of adoption and encouraging widespread adoption?
Yeah. Well, we had a pretty early, um, a pretty early blow, kind of a shot across the bow, I guess you would say, from Charlie Rockwood. I think it was 1985 when he published a one-page editorial in the Journal of Bone and Joint Surgery about why people are way too enthusiastic about arthroscopy, and that it was going to be, there would be a lot of complications. And I think that was the article where he even said that he had some friends that were good arthroscopists that told him it took them about 100 cases to become proficient. And so he interpreted that as meaning that you have 100 experimental guinea pig patients that you've basically not done a good job on, and that's too high a price to pay for, all the thousands of orthopedic surgeons times 100 patients each for this to become the standard of care. And because Charlie had been the president of the Academy, I think about 82 or something like that. He was at the height of his power, not just in shoulder surgery, but in all of orthopedics worldwide. So he was like E.F. Hutton, when he spoke, people listened. And when you look at young guys in their 30s that are trying to go against somebody like that, it was pretty discouraging. The other thing that was kind of, it was particularly bad for me, I think, because being in San Antonio, where Charlie practiced just across town from me, this was, I'm sure, the single most hostile point in the universe to do shoulder arthroscopy. And I knew that if I had bad complications, they were going to end up in his clinic, and it would be bad for me. And I was very fortunate, like the first, I went a number of years before I had an infection, thank God. If I'd had an infection on my first arthroscopy, that probably would have been curtains for me. But the other thing that really helped me a lot, though, in the early days was the support of my group. I mentioned John Hinchy, who was the founder of our group. He had trained at Mayo Clinic, and after World War II, after World War II, he finished his residency and started practice in San Antonio in 1947. And then in 1972, he was president of the AAOS, which was unheard of at that time for a private practice guy to become president of the Academy. And so within our community, he carried equal weight to Rockwood, and he was very supportive of what I was doing, but cautionary and saying, you've got to be careful how you do this. And he really encouraged me to do the biomechanics and these types of things. So, I think it could have been a different story for me personally if I hadn't had a supportive group. I probably would have just gone into solo practice, which you could still do back then. But there were so many people that were so opposed to it. In fact, I knew of one orthopedic surgeon who was in a big group in a different state, and his partners saw how long it was taking him to do a case versus what it would take if it was open, particularly like an open meniscectomy versus arthroscopic. And they told him he needed to start doing open meniscectomies, and he said, "No, I'm not, because people do so much better with arthroscopic." They said, "Okay, you can keep doing them. We think you're crazy," and they made him undergo a psychiatric evaluation. And they said, if the psychiatrist says that you're not stable enough to be doing surgery, then we're not going to let you do this. So turns out the psychiatrist said, no, he's fine. He's just kind of stubborn, and he thinks he's doing the right thing. But that's the kind, if you think about the opposition, it wasn't only the big guns like Charlie Rockwood. It was the prevailing attitude was leaning more toward Rockwood because that's what people do. They look at the authority figures, and those guys are the rule makers, and they're going to follow the rules. So
certainly one of the things that you've gifted to the field is your legacy of teaching others maybe not to follow the rules. I mean, there's Paul Brady and Pat Denard and Ian Lowe and JT Tokish, and there's so many people in our field that would name you as a person that really influenced them. Share for us, how do those relationships, enrich your life? Like, what is mentorship meant to you?
Yeah, it means a lot. It's huge for me. And I never realized how much it would be, but the way I operated my fellowship, and not everyone you mentioned there is a past fellow of mine, but most of them were. But the way I operated my fellowship, it was like an apprenticeship. And the guys would spend a year with me. I had one clinical fellow spend a year with me. He scrubbed with me on every case. He was in the clinic with me on my clinic days. So, and then I would just gradually entrust him with more and more on the surgical side, but I was always in there. And so I ran it differently from the way some other guys did their fellowships, but you really get to know a guy that way. And it can be a very, when you have a really good fellow, or even if just, if you don't have a bad fellow, which I didn't really, to speak of, have any bad fellows, but if you have a really good fellow or just a good fellow, it's a pleasure to go and work with them every day. And they become your friend. And then to realize that they're going out and kind of carrying on your legacy, and they still call you and ask for advice on a tough case. And then when we started having our cowboy meetings, and I started trying to round up the whole crew again and have them help be my faculty. And just to a man, they were willing to do it. And it was so gratifying. And we had a big get together, and it was so interesting because the guys would comment over and over again that even though I just had typically one clinical fellow per year, and then I would have maybe one or two research fellows that were typically from overseas, because they couldn't, since I was in private practice, they couldn't get a Texas license to scrub with me in surgery. But they would comment on how when we'd all get together like that, they became good friends. And even though you don't think of that, of guys who may have done their fellowship 5 years apart or 10 years apart being good friends, but they were. It's as if they trained together. And I thought that was a very interesting observation. In fact, one of the most unforgettable days of my professional life was after our last cowboy meeting in San Antonio, and everyone knew I was retiring. It was just a couple of months before I retired. And the day after the meeting, I had everybody out to the ranch, and we would always have, we kind of had a routine. We would have a big Mexican dinner or Mexican food lunch, and then we would go out, and sometimes guys they had their kids would go fishing in the lake, but we would always have a shooting contest. We would shoot trap, the clay targets, and it was a big competition, and becoming the winner was a very coveted prize. And so anyway, we'd had the lunch, and it was time to go out and shoot the trap. And I said, okay, guys, let's all get together, and we're going to go down and to shoot the trap. And Paul Brady said, oh, no, we have to go for a hike. And I said, Paul, we never go for a hike. Well, then my wife, Nora, said, oh, yeah, we're going for a hike this time. We're going to change it up a little bit. Well, it turns out and I knew something was up then. It turns out we have a lot of hiking trails out on the ranch, and they had dedicated, or they were going to dedicate one trail as the Fellows Trail, and we went out to this. And Rob Hartzler actually had printed up all of these. They were little plastic replicas of what was going to be brass plaques for each fellow with his name and the date that he was my fellow and his favorite quote from one of the cowboy books. And then so we walked along this trail, and there were these big boulders all along the trail, and each one chose their boulder where they wanted their plaque to go. And each time we stopped, and we went chronologically by year, so each time we stopped, the guy, he knew he was coming up because it was his year, and then they just had so many wonderful things to say, and it just, and I felt like sort of like that Lou Gehrig thing where the guy's dying of ALS, and he says that they have Lou Gehrig at Yankee Stadium, and he says, "I feel like the luckiest man in the world." So fortunately, I didn't have Lou Gehrig's disease, but I felt like the luckiest guy in the world.
That's great. That's great. Now, I was wondering if I could bring in Rob, on the other side of that relationship. Can you, and take as much time as you like, but can you share how the impact of having a leader like Steve Burkhart has been impactful on your career, both personally and professionally?
So, Brian, I think the first thing that I want to say is I feel a little bit like, you'll have an assistant in arthroscopy who is kind of, you realize in surgery, they've stopped paying attention, and they just, they're enjoying the show. They're not really helping you. So that's kind of been my role here in the podcast. So, great show so far. It's tremendously enjoyable to hear Steve talk about all of these things. And I've just spent, the show feeling so grateful that, that he's my mentor all through training, and continues to be. And so, Steve, thank you for that. When you have your own fellows, you realize what a labor of love it is, to train someone. And so, as time goes by, I think, even more appreciate all of the time and energy and headache that your mentors, all of those things that they put into you and then put up with about you. So, but yeah, it's hard to overstate the impact of Steve on my life. And I just, feel super lucky that I, met the Burkharts, and that, Steve saw something in me, maybe even that I didn't see in myself. And it's just been a great ride to be trained by him and to continue to carry on the mission, so to speak, of trying to improve shoulder surgery, trying to do great surgery for my patients, and continue, leadership in our group, and trying to make an impact in that way, in South Texas, and sort of, continuing to try to promote the techniques that Steve came up with and pioneered, and was able to, all of the things that took, that were such a big part of his life, and now seem to be the standard of care, and just continue to promote those. So, yeah, I don't know if did that answer the question, Brian?
Yes, of course it did, Rob. I know it's hard to put you on the spot and have you synopsize what this almost father and son like relationship means to you, but I can tell you that we've all looked on it fondly, and we can tell how much he cares, and how much he's infused his professional and personal identity in the folks that he's taught.
Yeah.
I also think that we should not underestimate here. I mean, I don't want to belittle Steve. You've made huge contributions, but Rob has also made great contributions. I mean, and
Yes.
it's a testament to your own teaching. I mean, Rob, it's a huge honor to have even you on the podcast. And it's funny here because you're like it's like a father-son thing we've got going on. It's amazing to have both of you on. You know, Steve, you've made so many huge contributions from a research perspective, and you mentioned, the biomechanical work. And I think so many people in the field have read your papers. Your work carries on now with the Burkhart Research Institute in Orthopedics at TCOG. I want you to think back on the hundreds of publications. What was the publication or research finding that you're most proud of looking back?
Yeah, I think the one that, well, I'll tell you, it's hard for me to say because the area that's always been of the greatest interest to me is the rotator cuff. But when you think about all of the things, I mean, starting back with the, balanced force couples and, the rotator cable, the subscapularis repairs, double row repairs. We had the first paper on double row repairs, but they all built on each other, and each one made it better. I think so. I'm proud of those. I think collectively as a group of papers that kind of tells the whole story, like as if they're chapters in a book. If you want a good short story on a shoulder topic, but the article, the single article that made the biggest splash was the one on bone loss with instability with Joe DeBeer from 2000, and which is still, I'm told by Jim Lubowitz, still the #1 most cited article ever in the arthroscopy journal. And that made a huge splash, and it got people headed over toward recognizing bone loss. I mean, before that, to me, bone loss was one of the single biggest unsolved problems in malpractice, and that Lattershay solved that for me. And then to then later, 14 years later, I think, to be involved with Itoy and DiGiacomo on that follow-up paper on the on-track, off-track lesions, to kind of round out the rest of the theory, or basically to put more precision onto it on the humeral side anyway. And that was so those two papers together, I think of them kind of as a box set of papers that kind of rounded out the instability part. But I think the reason that two papers can tell more of a story than the 100 papers or whatever on rotator cuff. I think rotator cuff has so much more variability to it, and because of that variability, it's potentially that much more complex that it's hard to choose just one paper out of all that. I'm just proud of the kind of the progression of starting with simple things and recognizing biomechanics, and then how the biomechanics applies to the anatomy, and having had the anatomic descriptions. The other thing, you've got to remember, when we started doing shoulder arthroscopy, very few people, I mean, there were just a handful of people that ever saw the inside of an intact shoulder without having destruction of layers of tissue on the way in. So looking at the undersurface of the cuff, or looking at the interior of the shoulder with the labrum, that was unheard of. And so there was no concept of what's normal, what's abnormal, what may be an anomalous structure, and there was no language arthroscopy. So in order to be precise about anything, you have to have words to describe it. So there was a lot of thought and energy that went into the language of arthroscopy. So it really was very interesting to think about how many different facets to the project of this whole paradigm shift from open to arthroscopic surgery of the shoulder, how many different facets there were.
That inverted pair article was very influential to me as a young military arthroscopist. One of my attendings always used to say, "The eye does not see what the mind does not know," and I was always struck by how much bone loss we were accommodating in performing our labral pairs. So I just want to thank you for guiding our hand towards where we are now, which is so much more of a nuanced appreciation for the glenohumeral instability picture. I'm
Yeah.
curious, you've always had your fingers on the pulse of the shoulder community, and I was hoping you could help us predict what the next frontier for us is. What's that next wave of technological advancement?
You know, I read about things that sound very interesting and that I think could potentially be very disruptive, but I don't know much about. And some of these the biologic enhancements and manipulations, and even things like the senescent cells. Senescent cells that basically contribute toward inflammation, and if finding ways to rid the body of senescent cells so that your rotator cuff can heal more quickly or more reliably. So, and that's one thing I've read about in recent years, that experimentally produced rotator cuff tears can heal more quickly if you give oral medication to reduce the number of senescent cells like losartan or fisetin. So, I think there are things like that I probably don't even know about now that could be really pivotal. I think that it's going to be hard. I'm not saying it's impossible, but it's going to be hard to make huge changes in the fixation unless there is something biologic, like a biologic glue, where there's not really any implants that you put in. And I don't know if there's going to be something like that, but there might be something like that. But we've had so much trial and error already on the biomechanics, and it's led us to where we are. And it keeps improving, but it's incremental improvement. It's not disruptive improvement. So I think I probably am fortunate that I came along when I did, because my area of interest and expertise was more mechanical, and so it just happened that stuff was just waiting to be discovered at the time, and waiting to optimized, I guess is the right word, not discovered, but waiting to be optimized when I came along.
That's fantastic. And we could obviously sit here and talk for hours. I can speak personally for Peter and I that to hear the annals of history and have you unpack things the way you have has just been such a delight. I think it's definitely an instant classic with one of the all-time greats in you,
Well,
Dr. Burkhart.
and I'll tell you one quick story, and you can cut it out if you need to, if you don't have time. But I think back to a medical meeting, I think it was in 1997, where Peter Habermeyer had invited me to Heidelberg for this meeting he was starting to have, became an annual meeting. But he asked me to talk on arthroscopic cuff repair and to show videos of it. So I did, and I showed a video, about a 5-minute video, and explained all the steps, highly edited. And as we were walking through, it was just before break, we were walking to get some coffee after that, and Peter was walking with me, and some guys stopped him, talked in German for a while, and then he came over to me. He said, "You're not going to believe what these guys were saying to me." They said Burkhart's thing was the typical deal that you'd expect to come from some hotshot American. It's kind of like like the moonwalk or something, that it clearly was made in some Hollywood studio, because that can't be done. An arthroscopic cuff repair can't be done. And so anyway, he thought I would get a kick out of that. So if you ever think about people discouraging you and saying it can't be done, then just put on your game face and keep at it.
Well, certainly we love to hear these stories. And what I think for all of our listeners that are listening to this that can go and tackle that challenge, we're all indebted to you for your wisdom, your courage, your commitment to paying it forward, and mentorship, and the friendship you've given to so many members of our field. So I thank you. I mean, it's really an honor for us to have us, and for us to have you on the podcast, and for us to listen to the history and the story behind all the accomplishments you've made. So for all of our Shoulder Nimble listeners out there, don't forget to subscribe. And for Brian Waterman, I'm Peter Chalmers, and we will see you next time.